So, good morning, students. Today I will be talking about two uh, instruments: lumbar puncture needle and liver biopsy. These two needles, they may be kept as spotters. You have to identify the needles and write 2 points so that you can get your marks. You have to identify there are 3 needles. The bone marrow aspiration needle is one, the lumbar puncture needle is one, and the other one is the liver biopsy needle. These 3 needles are there. Any one will be kept as a spotter for you. So not only that, in the afternoon session during the Viva, one examiner will be sitting with all the instruments. So he may ask you to pick up one instrument and tell whatever you know about that particular instruments. Or he may give you one instrument and ask questions regarding that instrument. So today's topic is on two needles. One is the lumbar puncture needle. So lumbar puncture needle. So the lumbar puncture needle is used for drawing the CSF. So I will tell you some basics about the CSF so that it may be useful. So CSF, how is the CSF formed? CSF is the ultrafiltrate of the plasma. CSF is ultrafiltrate of the blood plasma. It is formed by the choroid plexus in the ventricles, the lateral ventricle, the third ventricle, the fourth ventricles of the brain. CSF is the ultrafiltrate of the plasma. It is formed by the choroid plexus of the lateral ventricles, the third and the fourth ventricles in the brain. The CSF is present in the ventricles, in the spinal canal, and in the subarachnoid space. The cerebrospinal fluid is present in the ventricles of the brain, in the spinal canal, and in the subarachnoid space. So the CSF is absorbed into the blood through the arachnoid villi on the dural venous sinuses. So CSF is absorbed through the arachnoid villi on the dural venous sinuses. So this is about something about CSF. So what is the composition? The composition of CSF, the volume of the CSF in adult is 100 to 150 ml. The volume of the CSF in adult is 100 to 150 ml. The CSF pressure is 60 to 180 millimeters of water. CSF pressure in a normal individual is 60 to 180 millimeters of water. CSF appears clear, water-like. CSF normally appears clear and colorless like water. So the number of cells is 0 to 5. Less than 5 cells are present per millimeter cube in adults. The CSF, the volume of the CSF is 100 to 150 ml. Normally CSF is clear and colorless like water. The normal number of cells in CSF is less than 5 cells. These 5 cells are mostly mononuclear cells. Lymphocytes are there. Less than 5 cells per cubic millimeter. Most of the cells are lymphocytes. So the glucose and protein values in the CSF. Glucose concentration is 45 to 80. The glucose is 45 to 80 milligrams per deciliter. Protein is 15 to 45 milligrams per deciliter. The glucose concentration of the CSF is 45 to 80. That is 2/3 of the plasma. The plasma value divided by 2/3 will give the CSF glucose. So the CSF glucose is 45 to 80 and the CSF protein is 15 to 45 milligrams per deciliter. The CSF protein is 15 to 45 milligrams per deciliter. It is 1% of the plasma. CSF protein is 1% of the plasma. Normal CSF glucose is 45 to 80 milligrams per deciliter. Normal CSF protein is 15 to 45 milligrams per deciliter. So what is the function of CSF? The function of the CSF, it is protects the brain and the spinal cord from injury by acting as a shock absorber. So the function of the CSF is it protects the brain and the spinal cord from injury by acting as a shock absorber. It serves the function of nutrition, providing it serves the function of it serves as a medium between the blood and the brain to supply the nutrients and remove the waste products. It serves the function of a medium between the blood and the brain to supply the nutrients and remove the waste products from the brain. So this needle is a lumbar puncture needle. You can see the lumbar puncture needle. This is the lumbar puncture needle. So lumbar puncture needle is a very fine needle, very thin and long. Whereas the bone marrow aspiration needle is a stout needle, which is very strong and has a guard. Stillet is there in case of bone marrow aspiration needle. Whereas in lumbar puncture needle, you can see a very thin needle is there, which is very delicate. No guard is there. So this is a lumbar puncture needle for aspirating the CSF, cerebrospinal fluid, lumbar puncture needle. So you have to identify this one. This will be there in the spotters. When a thin needle is there, which is a very delicate one, it is a lumbar puncture needle. So the purpose of the uses of the lumbar puncture needle. Lumbar puncture needle is used for obtaining the CSF, cerebrospinal fluid, for analysis and diagnosis of meningitis. So the indications for the lumbar puncture are meningitis, meningoencephalitis, subarachnoid hemorrhage. In malignancy, if there is a meningeal involvement or not. To know whether there is involvement of the meninges, we can do the lumbar puncture. Pseudotumor cerebri, other neurologic symptoms. So the main indications for the lumbar puncture are meningitis, meningoencephalitis, subarachnoid hemorrhage. To obtain CSF and reduce the intracranial pressure. Sometimes there is benign in case of intracranial increase in the CSF pressure, then we drain the CSF to reduce the intracranial space. To install medications. So for anesthesia, medications are given with the help of the lumbar puncture needle. So this is the purpose of the use of lumbar puncture needle. So what is the procedure? How will we collect? So the indications of the lumbar puncture are, in case of CNS infections like meningitis, meningoencephalitis, when there is meningeal involvement in case of leukemias, malignancies, when there is a subarachnoid hemorrhage, if CT is contraindicated. If CT is not available, if CT scan is not available, then we can go for lumbar puncture in case of subarachnoid hemorrhage. For administration of medications, anesthesia, for administration of medications in case of spinal anesthesia, for introduction of radio contrast media in case of myelography. We want to take the scan for the spinal cord. Then we introduce a radio contrast material into the spinal canal and we will do the myelography. So these are the indications. Lumbar puncture needle is used for aspirating the CSF in case of meningitis, meningoencephalitis, and subarachnoid hemorrhage. To install medications in case of spinal anesthesia. To reduce the CSF pressure in case of intracranial, increase in the intracranial pressure. So these are the indications. So what are the contraindications? The contraindications are increased intracranial pressure. When there is marked increase in the intracranial pressure, when there is a high head CT before study, if focal neurologic findings present to rule out an impending cerebral mass herniation. So if there is a cerebral mass, if there is an impending cerebral mass herniation, then CT, this is indicated, lumbar puncture is indicated. So raised intracranial pressure due to space occupying lesion. Raised the contraindication for the lumbar puncture is increased intracranial pressure due to space of pine lesion like brain abscess or posterior fossa tumor. When there is a posterior fossa tumor or abscess in the cerebral abscess, if you do the lumbar puncture, there is a risk of herniation of this cerebrum. So then it is the lumbar puncture is contraindicated. In case of cardiorespiratory compromise, in case of cardiorespiratory compromise, in case of bleeding diathesis, these are the contraindications. The contraindications for the lumbar puncture are raised intracranial pressure due to space occupying lesions such as brain abscess or posterior fossa tumor, cardiorespiratory compromise. Third one is bleeding diathesis. It is that is not corrected if the platelet count is less than 50,000, not 40,000, 50,000. And prothrombin time is less than 50% of normal control. These are the contraindications in case of bleeding diathesis, in case of posterior fossa tumors. When there is increased intracranial pressure, these are the contraindications. So the indication for the lumbar puncture are meningitis, meningoencephalitis, subarachnoid hemorrhage, and for anesthesia, spinal anesthesia. The indications for the lumbar puncture are to collect to CSF for the CSF analysis in case of meningitis, meningoencephalitis, subarachnoid hemorrhage, and also to inject medications in case of spinal anesthesia. These are the indications. The contraindications are increased intracranial pressure in case of posterior fossa space occupying lesion like cerebral tumor, posterior fossa tumor, or a brain abscess. These are the contraindications. The other contraindication is if there is a bleeding diathesis, platelet count less than 50,000. These are the contraindications. So what is the exact site where the lumbar puncture is done? The lumbar puncture is usually done at the level of L3 and L4 in the intervertebral space, L3 and L4. This is the space. Sometimes L4 and L5. So L3 and L4 is the usual site where the lumbar puncture is done. But sometimes L4 and L5, the space, the intervertebral space between the L4 and L5 is also used for the lumbar puncture. At the level of T12, the spinal cord ends, and there is no risk of injury to the spinal cord at L3 and L4. So L3 and L4 is the site where lumbar puncture is done, and sometimes L4 and L5 is also used. So this is a needle. This is the site where the needle is inserted. L3 and L4. The needle is introduced into the subarachnoid space through the intervertebral space. So in between the intervertebral space, the needle is introduced through the intervertebral space. Needle is introduced. The needle is introduced into the subarachnoid space through the intervertebral space. So what are the tissues which are pierced? The tissues which are pierced from outside inwards are, first one is the skin, the subcutaneous tissue, then the interspinous ligaments. These ligaments are there. The supraspinal ligament, interspinal ligament, ligamentum flavum. Then there is a thin layer. This is a dura mater and arachnoid mater. They are very closely, the dura and the arachnoid, they are very close together. And then we enter the subarachnoid space. In the subarachnoid space, there is a CSF. So the skin, the subcutaneous tissue, the interspinal ligaments, the ligamentum flavum, the dura and the arachnoid are closely applied, close to one another. There is not much space, and then we enter the subarachnoid space. So while piercing, there is suddenly a giveaway feeling when we enter the subarachnoid space. So the lumbar puncture needle is passed between the L3 and L4 to collect the CSF from the subarachnoid space to prevent injury to the spinal cord, as the spinal cord ends at about T12. At the level of T12, the spinal cord ends. So to prevent injury to the spinal cord, the lumbar puncture needle is passed between the L3 and L4, or sometimes L4 and L5. So it is far below T12. T12 where the spinal cord ends. So the procedure. So the position, the procedure, the patient is asked to lie in the lateral position. So the spinal cord, the patient is asked in a lateral decubitus position with the maximum flexion. Maximum flexion is there without compromising the elbows. So keep the knees, feet, and the hips in one line. Keep the knees, hip, and the feet in one line, and the position of the head, position head to left if right-handed, or vice versa. So the patient lies in a lateral decubitus position with completely flexed posture. So this flexion will increase the space between the vertebrae, between the spinous process of the vertebrae, so that the interspinal space is visible and we can pass the needle. So the equipment which is needed: a sterile CSF tray, the spinal needle. So here you can see the spinal needle. Spinal needle is there, a very thin needle. So this is the cerebrospinal needle, CSF needle. Very thin needle, fine needle. So this is a cover. The spinal needle, you can see a very thin needle and delicate, without any guard. This is a spinal needle. So you should be able to identify this thing during your exams. So this will be kept like this. During your exams, this will be kept like this. A very thin needle is there. So here you can see. So a spinal needle, the equipment needle, the spinal needle, the anesthesia, the topical anesthesia is the xylocaine or the lignocaine, 1% anesthesia, a syringe with 25 gauge needle, so and powdered in iodine, and a sponge, drapes, gaze, the bandages. These are the things which are needed. So the procedure. Before doing the procedure, we take a written consent from the patient. A written consent. We explain the procedure to the patient, and then determine whether patient has any doubts or misconceptions about the procedure. They reassure the patient and instruct the patient to void only after the procedure. Instruct the patient to void after the procedure. These are the pre-procedure instructions. So during the procedure, the patient lies in a lateral decubitus position, and a small pillow is placed beneath the head and in between the legs, and assist the patient to maintain the position, encourage the patient to relax and breathe normally, and describe the procedure step by step. We will describe the procedure, what are we doing step by step. So the patient first cleans the site where L3 and L4 site, after covering with the sterile cloth. The local site is cleaned with initially with first with spirit and then with the powdered iodine. It is with the help of drapes. A gauze piece is there. We just clean the site where the CSF puncture is done. Then a local anesthetic lignocaine is injected between L3. First, infiltration is done into the skin, and then slowly the needle is introduced into the subvertebral space. Then a spinal needle is taken. A spinal needle, after confirming that the local area is anesthetized, we introduce the lumbar puncture needle slowly into the L3 and L4 site. A specimen of the CSF is collected. Then after entering, while entering, suddenly a giveaway feeling is observed. We remove the stellate, and we will have 3 tubes. We will collect the CSF in all the 3 tubes. About 3 to 5 ml is collected in each 1 ml in each tube. 3 tubes are taken, sterile tubes are taken, and in each tube 1 ml of CSF is collected. The specimen is collected usually in 3 tubes. The needle is drawn, and small dressing is applied at the puncture site, and the specimen is sent to the laboratory. So these 3 tubes, 1 tube is sent to the biochemistry for the CSF glucose and protein. One tube is sent to the microbiology for culture sensitivity and for gram stain. and one tube is sent to the pathology. Pathology for the total count and the differential leukocyte count. So the CSF is collected in 3 separate tubes, 1 ml in each tube, one tube to the biochemistry for assessing the CSF glucose and the protein, one tube to the biochemistry for staining for the gram stain and for the culture sensitivity, and one tube to the pathology department for the TC and the DC for the differential count and the total leukocyte count. And another 1 ml is used for any immunologic tests. For other any special immunologic test, 1 ml is also preserved. So post procedure, the patient is asked to lie in prone position for 2 to 3 hours and monitor the patients for any complications. Encourage the patient to take fluid intake. Increased fluid intake is advised after the procedure. The complications of the CSF lumbar puncture are headache, very rare. Headache is the commonest. Backache occasionally with short-lived, which is short-lived. Disc herniation if needle is advanced too far. So bleeding or fluid leak around the spinal cord. Infection, pain, hepatoma. Subarachnoid epidermal cyst, ocular muscle palsy, nerve palsy, brainstem herniation. These are the complications. The most common complication is a headache is the most common complication of CSF, of the lumbar puncture. So the CSF analysis, CSF is a clear and colorless fluid. It is secreted by the choroid plexus. It exists through the subarachnoid space. The total volume is 150 to 200 ml. It acts as a shock absorber, transports the nutrients. So the standard tests are the biochemistry tests, protein and glucose. Protein is 15 milligrams to 45 milligrams. Glucose is 45 to 70 milligrams per deciliter. Bacteriological for microbiology, we will send for the gram stain and the culture. And for the pathology department for knowing the total count and the differential leukocyte count. These are the tests which are usually done on the CSF. So after obtaining the CSF, the values, based on the values, we can come to one conclusion. So normally the CSF is clear. The CSF pressure is 90 to 180 millimeters, less than 5 cells. 0 to 9 is 0 to 8 or 9 is a normal number of mononuclear cells. Normally lymphocytes are there. About 5 to 8 or 5 to 9 lymphocytes are present in a normal adult individual. The protein is 15 to 45 milligrams per deciliter. But in case of acute bacterial meningitis, so meningitis can be bacterial meningitis, viral meningitis, tuberculosis meningitis, or fungal meningitis. These are the various causes of meningitis. If the CSF is turbid, CSF pressure is increased, and the total count is between 1000 to 10,000, and most of the cells are neutrophils, then it is acute bacterial meningitis. In case of bacterial meningitis, the WBC count is markedly increased, 10,000 to 10,000, and most of the cells are the neutrophils. Normally lymphocytes are there, and majority 90% of the cells are neutrophils in acute bacterial meningitis. And in bacterial meningitis, the CSF protein is elevated. In acute bacterial meningitis and tuberculosis meningitis, the protein is elevated. In acute bacterial meningitis and tuberculosis meningitis, the protein is elevated. In acute bacterial meningitis and tuberculosis meningitis, the CSF glucose is decreased. CSF glucose is decreased in acute bacterial meningitis and tuberculosis meningitis. So next, coming to the viral meningitis. In case of viral meningitis, the CSF is clear, and the cells which are increased are lymphocytes. In viral meningitis, the cells increased are lymphocytes, not neutrophils. Neutrophils are increased in bacterial meningitis, acute bacterial meningitis. In viral meningitis, lymphocytes are increased, about 300 cells are there. So the protein is normal or mild, slightly increased in viral meningitis. The glucose is normal. So the differentiation between the viral and the bacterial meningitis is the protein is elevated in bacterial meningitis, whereas protein is normal in case of viral meningitis. In bacterial meningitis, protein is decreased, whereas in viral meningitis, protein is normal. And the cell count is markedly increased. Neutrophils, 90% of the cells are neutrophils. 1,000 to 10,000 cells are there in case of acute bacterial meningitis. In viral meningitis, lymphocytes are increased, but they are around 300 only. Another one is a tuberculous meningitis. In tuberculous meningitis, when you allow the CSF to stand for some time, there is a formation of cobweb coagulum. The CSF, when is allowed to stand, it forms a cobweb coagulum. Slightly opacity is there. When you keep it like that for some time, a cobweb coagulum is there inside the CSF. And the CSF pressure is increased or decreased. But the main thing is the WBC count. Here, it is more than the, in case of viral meningitis, 300 cells are there, lymphocytes. But in case of tuberculous meningitis, they may be increased up to 600. Most of the cells are lymphocytes. In tuberculous meningitis and viral meningitis, lymphocytes are there. In viral meningitis, around 300 cells are there. In tuberculous meningitis, slightly more cells, 600 lymphocytes are there. So the protein is elevated, the glucose is decreased. So that is about the various forms of meningitis. Fungal meningitis, it is CSF is clear, and mixed cells 40 to 400 cells are there. The protein is 50 to 300. The glucose is decreased. The chloride is also decreased. So overview. So this is bacterial meningitis. I have told you the pressure is elevated. The CSF is turbid. Mainly polymorphic neutrophils are there. Glucose is decreased in case of bacterial meningitis, acute pyogenic meningitis. Protein is elevated. When you do the gram stain, you may find organisms. Organisms may be present. In viral meningitis, the WBC are elevated. CSF glucose is normal. Protein is also normal. Actually, not elevated. Protein is also normal. So, what is this needle? This needle is a liver biopsy needle. Very strong needle is there. So, when you remove the stellate, this is the needle and there is one stellate is there. When you remove the needle outside, you can see that the needle is a bifid. The needle is bifid. If you remove the needle and observe, if you remove the stellate and observe the needle has a bifid tongue. So this, when you find a needle with a bifid tongue, it is a liver biopsy needle. Bims Silverman liver biopsy needle. This needle is called Bims Silverman needle biopsy needle. So we have three needles. One is bone marrow aspiration needle, a stout needle with a guard. In case of bone marrow aspiration needle, you will have a guard over there. That is the main difference. In liver biopsy needle, it also appears like bone marrow aspiration needle, but the stellate is the needle is bifid. Needle is bifid and long needle is there. That is a liver biopsy needle. Very thin needle, which is very delicate. This is a lumbar puncture needle. Very delicate needle is a lumbar puncture needle. So coming to the liver biopsy. So here you can see the liver biopsy needle very clearly. The needle is bifid. Bifid needle. Here this is a stellate. Stellate is there, and this is a needle which is bifid. So who will perform the liver biopsy? A hepatologist, a gastroenterologist, a radiologist, a pathologist, or a surgeon. So any of these people can do it. But usually a gastroenterologist, a hepatologist, or a radiologist. These people will perform the liver biopsy. A hepatologist, a gastroenterologist, or a radiologist. These people usually do the liver biopsy. What is a liver biopsy? So liver biopsy is a procedure in which a small piece of the liver tissue is removed and examined microscopically to determine the cause and the severity of the liver disease. So liver biopsy means a small piece of the liver tissue is removed with the help of a needle. It is examined under microscope to know what is the cause of the disease and what is the severity of the disease. That is called liver biopsy. Liver biopsy is a procedure in which a small piece of the liver tissue is removed and examined microscopically to determine what is the cause of the liver disease and to determine the severity of the liver disease. So there are different types of liver biopsies: percutaneous liver biopsy, transjugular liver biopsy, guided liver biopsy. So usually this percutaneous, this percutaneous liver biopsy is done by the hepatologist or the gastroenterologist. Guided biopsy is also done by the gastroenterologist. Gastroenterologist. Transjugular liver biopsy is done by radiologist. Radiologist does the transjugular liver biopsy. So the procedure which is done in usually in the hospitals is the percutaneous or the ultrasound radiology real-time guided biopsy. So there are different types of needles. So the needle which we will keep for the needles are suction needle, cutting needle, spring-loaded needle. The needle which we have for your examination as a spotter is Wim-Silverman needle. Wim-Silverman liver biopsy needle is the thing you have to write during your spotters. Wim-Silverman liver biopsy needle. That is the actual you have to write when this spotter is cut. You have to write Wim-Silverman liver biopsy needle. So the ideal biopsy needle should be 1.4 to 1.8 millimeters in diameter. Wider bore needles are associated with huge risk of complications. So the needle is Wim-Silverman liver biopsy needle. So here, this is not there. The first true cut needle, the initial figures which I have shown, that is the liver biopsy needle. So the indications for the liver biopsy needle. The indications for the liver biopsy needle are when you don't know the cause of hepatitis. In a case of acute hepatitis, when you don't know the cause, acute hepatitis of unknown cause is an indication. Chronic liver disease. Chronic liver disease is there, but you don't know the cause. To define the cause of the chronic liver disease, to grade the inflammatory activity, for staging of the chronic hepatitis C and hepatitis B, and monitor response to therapy. So these are the main indications. In acute hepatitis of unknown cause, in chronic normally for viral acute hepatitis B and hepatitis C, we won't do a liver biopsy. In a case of acute hepatitis of unknown cause, we do liver biopsy. In case of chronic hepatitis, to know the cause of the chronic hepatitis, to know the grading, to know the staging of hepatitis B and hepatitis C, to know the amount of inflammatory activity, we do the liver biopsy. To know the grading of the inflammatory activity. For diagnosis of some metabolic disorders like hemochromatosis. In hemochromatosis, there is accumulation of iron. Quantity, there is accumulation of iron. Similarly, in case of Wilson's disease, in Wilson's disease and hemochromatosis, for quantitative estimation of the iron levels and quantitative estimation of the copper levels, we will do the liver biopsy. So these are the main indications. There is other indication is a primary biliary cirrhosis and primary sclerosing cholangitis. So the indications for liver biopsy are acute hepatitis of unknown cause, chronic hepatitis when you don't know the cause, for grading of the inflammatory activity, for grading and staging of hepatitis B and hepatitis C, in certain metabolic disorders like hemochromatosis, to estimate the iron levels, amount of iron accumulated in the liver, for diagnosis of metabolic disorders like Wilson's disease, for quantitative estimation of copper levels, for evaluation of the cholestatic liver disease, primary biliary cirrhosis, and primary sclerosing cholangitis. These are the main indications. So if the liver biopsy needle is kept, you have to write this is a Wim-Silverman liver biopsy needle. The indications are acute hepatitis of unknown cause, chronic hepatitis when you don't know the cause, for grading of inflammatory activity, for diagnosis of metabolic disorders like hemochromatosis, hemosiderosis, for evaluation of cholestatic liver disease like primary biliary cirrhosis and primary sclerosing cholangitis. So the other tests, these are also the indications. And some liver mass is there, you can go for liver biopsy to know whether it is a malignant tumor or benign tumor. to know the efficacy on the adverse effects of our treatment regimens, for evaluation of the status of the liver after transplantation or of the donor liver before transplantation, for evaluation of the pyrexia of unknown origin. So these are the some of the indications where liver biopsy is done. So the percutaneous liver biopsy. For percutaneous liver biopsy, what we do is first we auscultate. So for the prerequisites before doing the liver biopsy, prior imaging is to be done to identify any abnormality and define the borders. The prerequisites are the patient should be cooperative. If the patient is uncooperative, there is a risk of laceration and there is a risk of hemorrhage. So the prerequisite is, the main thing is the patient should be cooperative. And the other one is there should not be any extrahepatic biliary obstruction. If there is an extrahepatic biliary obstruction, there is a risk of puncturing the bile duct and there is a risk of biliary peritonitis. So the prerequisites are, one is the patient should be cooperative. There should not be any extrahepatic biliary obstruction. If there is an extrahepatic biliary obstruction, the bile ducts are dilated. There is a risk of puncturing the bile ducts and there is a risk of biliary peritonitis. There should be no bleeding diathesis. That is, the platelet count should be greater than 50,000. The prothrombin time should be about greater than 3 to 5 seconds above the control value. The platelet count should be greater than 50,000. The bleeding time should be greater than 10 minutes. So if liver biopsy is essential, then we administer the platelets, we administer the FFP. FFP is rich in coagulation factors, vitamin K, and then go for liver biopsy. In case of tense ascites, if the patient is having tense ascites, the margins of the liver are not clearly defined. So there is a failure of liver tissue in case of tense ascites. In case of hydatid cyst, if you do the liver biopsy, there is a risk of spreading the hydatid disease to other parts of the body, and there is also a risk of anaphylaxis. And another contraindication is in case of highly vascular neoplasm. If there is a vascular neoplasm, if you do the biopsy, there is a risk of hemorrhage. So these are the contraindications. The contraindications are, if the patient is not cooperative, it is contraindicated. If there is extrahepatic biliary obstruction, there is a risk of biliary peritonitis. If there is a bleeding diathesis, platelet count greater than 50,000, bleeding time greater than 10 minutes, then it is contraindicated. If there is a tense ascites, don't go for liver biopsy. If there is hydatid cyst, there is a risk of anaphylaxis. If there is a vascular neoplasm, highly vascular neoplasm, if you do the liver biopsy, there is a risk of hemorrhage. So these are all the contraindications for liver biopsy. So before doing the procedure, we should mark the liver bolus by percussion or with the help of the scan, mark the liver bolus. And the routine hemogram should be done. The bleeding time, the coagulation profile should also be done. An informed consent is to be taken. The blood grouping and cross matching should be done. So these are the prerequisites. So the prerequisites are before going for liver biopsy, the liver margins, the prior imaging of the liver is done to identify the margins, any abnormality, or to define the borders. The routine hemogram is to be done. The coagulation profile should be done. Informed consent has to be taken. Blood grouping and cross matching is to be done. So what is the method? Procedure. The patient lies in a supine position. The written consent is taken after explaining the procedure and all the baseline investigation, the coagulation profile, the prothrombin type, the hemogram, that is the complete blood counts. The patient lies in a supine position. Remove the pillows, elevate the right arm behind the head, percuss the right trunk to the point of maximum dullness, and during both inspiration and expiration, this frequently corresponds to the point along the mid-axillary line at the second or the third intercostal space above the costal margin. So mark this location with the surgical pen or other method. Prepare the field with betadine solution. Place sterile wraps. Administer 1% xylocaine in the superficial and the deep legs. So once adequate anesthesia is applied, a small nick is given on the skin with a surgical blade to allow the introduction of the biopsy needle. The needle is introduced within the close proximity to the upper aspect of the lower lip to avoid intercostal nerve and vascular damage. As the needle is introduced, a series of several successive pops may be felt. A small amount of saline contained in the syringe is flushed away until resistance is encountered. The resistance is the lever edge. At this point, the needle is withdrawn slightly and flushed again to remove debris. Suction is applied by the syringe and the patient is asked to expire and hold his breath. The liver biopsy is then taken. So during biopsy, the patient is asked to hold his breath in expiration. So after the biopsy, pressure is applied on the site followed by adhesive bandage. The patient is rolled onto the right side and instructed to remain in this position for a minimum of 1 hour to help prevent bleeding or biliary leakage. Vital signs are observed for every 15 minutes for the first hour and every 30 minutes during the second and the then hour. Patient is discharged if no signs or immediate complications are present. So that is about liver biopsy needle. So regarding liver biopsy needle, if a needle is there, which is very, so if you can see this, if the examiner, if you get this needle with a bifid tongue, then it is a silver liver biopsy needle. So the indications are acute hepatitis of unknown cause, chronic hepatitis when you don't know the cause, for grading the inflammatory activity in case of chronic hepatitis, for grading and staging of the chronic hepatitis B and C, in case of metabolic disorders, hemochromatosis, Wilson's disease, for quantitative estimation of the iron and copper accumulated in the liver. These are the indications of liver biopsy. In case of primary biliary cirrhosis, in case of primary sclerosing cholangitis, these are the indications. So if this needle is kept, you have to identify the needle, liver biopsy needle, and write the indications. Acute hepatitis of unknown cause, chronic hepatitis to determine the cause, hemochromatosis, Wilson's disease, primary biliary cirrhosis, primary sclerosing cholangitis. And what is this needle? What is this needle? Needle with a guard. So this is a Salas bone marrow aspiration needle. You have to write Salah, S-A-L-A-H, Salas bone marrow aspiration needle. If this is kept, you have to write 2 indications: pancytopenia, leukemia, subleukemic leukemia, ITP, Gaucher's disease, Niemann-Pick's disease. These are the indications. So what is this needle? Very thin needle is there. This is a lumbar puncture needle for aspirating the CSF, cerebrospinal fluid. Cerebrospinal fluid is needed in case of indications for lumbar puncture, meningitis, meningoencephalitis, for administration of drugs in case of spinal anesthesia. These are the indications. And the other one is the liver biopsy. So that's the today's class. You have to identify these needles. This is bone marrow aspiration needle, LP needle, and the other one is bifid tongue. Needle with bifid tongue is a liver biopsy needle. So that's it. Okay, thank you.